This is Dr. Bill Bird coming to you from CGH Medical Center. Glad that you're taking the chance to hear what we have going on here at CGH. I have a couple guests with me today, both of whom I think you're really going to enjoy. So our first guest is Dr. Sean Hanlon. Sean is an orthopedic surgeon he's very experienced. He's been here at CGH for a few years.
35.
Yeah.
35 years.
Yeah, so glad to have Dr. Hanlon here, and I'm going to start asking some questions of Sean right now, and then as you all have questions, feel free to chime in, and Dana will text them to me. And if you see me looking down at my phone, it's because Dana's sending me texts about questions you all have. So, okay, so here we go. You ready?
I think so.
Okay.
Yeah. It was my first time on Facebook.
It was mine too a few weeks ago.
Yeah.
So, what's the most challenging thing for you, Ben, since this COVID-19 situation started, Sean?
The thing that has been most challenging for us and has created the most, stress for me and my team has been the fact that our patients have had to have their scheduled surgeries delayed. I feel, if someone has devoted the effort and time to get ready for a big operation, they've made the decision, and I do a lot of joint replacements, so I'll talk specifically about that. Someone's made that very important decision in their life. They've gone through the necessary preparation for the surgery in terms of getting blood work done, seeing their primary physician, and they're on the verge of getting this operation done to solve their problem with painful knee or painful hip, and then all of a sudden they're canceled. So we had about 35 of our joint replacement patients get their surgeries canceled during the roughly 2 months that we were not doing elective procedures. And so those folks were had to be delayed. Early on, we had no idea when we were going to be able to get their surgeries done. I will say that my patients were very gracious about it. They understood the reason behind it. My team in the office, I have to give a shout out to them. Destiny and Jamie and Jennifer have done a great job keeping in contact with my patients and keeping them updated on developments and helping with rescheduling of the surgeries, which we've started to do, obviously. And so it's been, despite the difficulty, it's been pretty smooth.
So I'm gonna, okay, you're all right. We had a little technical glitch here, so
Okay. Did anybody hear any of that?
Let's see how much they heard.
Okay.
So,
Basically, the biggest challenge has been,
how much did they hear, Dana?
Not sure.
Okay,
Yeah.
so let's go, what I'm gonna do is go back and start, if you would, at that part about, you had 35 patients.
right, we had 35 joint replacement patients that had to have their surgeries canceled during the COVID phase.
You want to stop for a sec?
Just talk loud.
Okay, all right. Keep going, Sean.
Yep.
And so those patients, the frustrating part for them and for me was the fact that they had to have their surgery scheduled. These people wait for months.
Yeah.
And when they suddenly are told that we can't do it, it's a great disappointment. And so, as I mentioned, if you couldn't hear me earlier, I give a lot of credit to my staff in the office who have been great about keeping those patients informed and letting them know where we are in the process of getting things rescheduled, and in the startup that we've begun now and getting them back on the schedule.
Yeah.
And that's Destiny and Jamie and Jennifer in my office.
Yeah. How's your team figuring that out in terms of who you're going to have the surgery with first and that kind of stuff?
Of those that got canceled, those 35 joint replacements, and then there was probably 15 or 20 other elective surgeries.
Yeah,
so of those 50 patients that got their surgery scheduled, the way we are prioritizing them and rescheduling is the ones that were the earliest ones are going to get back on the schedule first, and then the ones that were later in that 2-month period will get on the schedule later. So, for instance, somebody who was scheduled for the 15th of March, which is about when we started the shutdown of elective surgeries, some of those patients have already had their surgeries. We started we resumed elective surgeries the week of May 11th. And so the ones that waited the longest were the ones that got on the surgery schedule the quickest. Obviously, we've always, throughout this, prioritized by need. Someone who has a condition that requires more immediate attention is going to get prioritized as well. And an example is throughout the period we did emergency surgeries as they were needed. But it's these elective surgeries that we're talking about that we're starting to get scheduled and starting to get them back in and get them done again.
How does that work? I'm guessing those 35 folks already know this, but just for the rest of the folks who are listening, in the hospital world, it's usually about a 30-day window from when the process starts to when they need to have the surgery, or you have to repeat some of that stuff.
Correct.
Like history and physicals, laboratory work. How are you guys managing
Right.
that?
And normally, within a 30-day time span before the surgery, a patient goes to their primary care physician and gets a physical done, and then they come to lab and have blood work, EKG, chest x-ray, and they usually meet with our anesthesia staff as well. Many of those patients that were canceled, in fact, most of them had already gone through this process. And so as we get them back on the schedule, we are, if it's been more than 30 days since their physical was done, we're asking their primary care physician.
So I think we last left off.
With testing.
With particularly the COVID testing,
Right.
and what's the process? You want to talk that through
Sure.
for folks?
Yeah. We, as part of our plan to restart our elective surgeries here at CGH, and based on the Illinois Department of Public Health guidelines, we are testing all of our elective patients within 72 hours of their surgery for COVID-19. So our patients are scheduled to have the test done. We're getting quick turnaround of about a day or two. And so those patients have a test result back before the surgery. We ask the patients to self-quarantine in their home during the time between their test and the day of their surgery. And so that's been working pretty well. Those patients that are admitted to the hospital more urgently, we have the capability to do a rapid COVID test, which gives us a result within an hour. But most of our elective surgeries are getting this 3-day, 72-hour ahead of time test that is sent to a reference lab, and we get those results back within a day or two.
And part, just so you know who are listening, we would love to have everyone do that one-hour turnaround test and just get that done the day of the surgery here.
Right.
But we just don't have enough of them right now. We only have a limited supply, so that's right now why we're doing that. And I would add one other thing. Also, part of what we're doing is the health department. I mentioned this last week, but the health department has been a very good partner in offloading some of the testing that we would normally do, which just allows us to have more tests available here at the hospital. So thank you to the health department for that. So we have the Cephia test that we're doing. So from a safety standpoint, can you talk me through, from your perspective, what we're doing here at the hospital side for your patients that are going through the process of having a surgery,
Right.
to keep them safe, to keep the staff safe,
Right.
all that stuff?
Well, it's really a continuum from office to hospital. So on the office side, when a patient comes in now, they are greeted at the door and screened before they come into the building. They answer a questionnaire, they have a temperature check, and they're provided with a face mask if they don't have one. So every patient walking into the clinic goes through that screening as they walk in. Once they're in our office, what we've done is we've scheduled lighter patient loads so our waiting rooms are not crowded. We have appropriate spacing in the waiting rooms, 6-foot spacing with the chairs in the waiting room. Once a patient hits our waiting room, we're doing our best to get them into an exam room immediately. So they don't wait in a waiting room, they're waiting in an exam room. As far as x-ray goes, instead of going to the x-ray outpatient side, we mentioned that all of our elective surgeries are getting the COVID test within 72 hours of their surgery. Again, staff in the hospital currently are wearing masks everywhere, so not just when we're with patients. or when we're within 6 feet of another person, but we're wearing masks throughout the entire day in the hospital.
This is one of your few opportunities to not wear a mask.
Right, this is great. This is
This
great.
is about it, right?
Yeah, most of the rest of the day, we're in masks here. So these are the things that are being done. I think it's our entire team, from administration, and the surgeons and the frontliners. We've worked together, the anesthesia staff. We've worked together to implement a plan for reinstituting our elective surgeries. We meet weekly. We have a team that meets weekly to update where we are with PPE supplies, where we are with testing supplies. And so on the week of May 11th, we started with 1/3 of our normal volume of surgical cases for elective surgery. Beginning Monday of next week, we're going to go to 2/3, and then we will continue to evaluate that on a weekly basis. But we are gradually and methodically working through that backlog of patients that were canceled to get all of those patients in and get their surgeries taken care of. And again, I'll thank my patients for being so gracious and patient throughout this period of time.
Good. You know, I was just curious, like when the patients are having the surgery and then afterwards, for those who are staying in the hospital for the total joints,
Right.
have you made any changes in terms of that process for patients, or is it still pretty much the way it was before the?
It's pretty much the way it was before. We had been working on shortening the post-operative hospital stay for my joint replacement patients, ultimately working toward outpatient knee replacement surgeries. Now, we're not there yet, but I'll give you an example. 10 years ago, it was not uncommon for a patient to stay in the hospital for 4 days after a total knee replacement. Today, patients are going home on the second day after surgery. Many of those patients might be able to actually go home on the day following. So if there's one thing that we're doing differently, it's trying to safely implement earlier discharge from the hospital. Obviously, we have there's a premium on hospital beds. If we were to get an increase in COVID-19 patients, we would need more hospital space. And so we're trying to get the patients out of the hospital earlier to free up those hospital beds. But also, I think it's becoming more and more clear that these patients can go home more safely earlier. So that's one change we've had.
Yeah. So in a nutshell, every week we just talk about this. I'm asking you point blank, and I know you work here, but it's still, I ask all the docs, do you feel like if you were a patient, you'd feel safe coming here to see you for an appointment or to have a surgery done here at the hospital?
Yeah, very much so. I think it's safer than going to Walmart, and if everybody's going to Walmart, safer than going to the grocery store. We're screening every patient. We're insisting that they all wear masks. Everybody in this building is wearing a mask. And as far as coming in for surgery, we're doing the appropriate testing for every elective surgical patient. In fact, every surgical patient is being tested right now. Even the emergency surgery patients are being tested with the rapid 1-hour test. And so I think it's as safe now as before. And when we weren't sure if it could be safe, that's the period of time when we elected to discontinue elective surgeries. And for almost 2 months, we were not doing elective surgeries until we implemented these programs to begin scheduling elective surgeries again in a safe manner.
Yeah. Good. I mean, I feel the same way, but I always ask our folks about that because there's definitely out there in the public. You know, you rattled off what I read this article today by a guy named I'm going to butcher the name, but like Atul Gawande. You know what I'm talking about? He wrote some of these checklist manifesto books and stuff, and he talked about the 5 pillars of infection control that hospitals are really doing a good job with throughout this outbreak. One is hygiene, so washing your hands and doing that on a regular basis. Distancing, staying a certain distance apart, which we're trying to do with our offices. Screening, which we're asking patients on ourselves. Masking, which we're doing. And the final one is culture. And in a hospital, I can tell you that we are really working hard at this. That sometimes is the final step, is to see someone that was walking down the hallway. It doesn't happen that much because our folks are doing a really good job with this, but I will tell you that when people are walking down the hallway and if I see the mask hanging a little low, I'll just say, hey, would you mind making sure you get that mask above
Right.
up to here, so that we make sure that you're safe and everyone else is safe around you. So at the hospital here, we are working really hard at all 5 of those pillars and making sure that we're doing that.
I think the culture piece has been big. I think everybody's, I've been amazed at how well that we have worked together, from administration to the doctors to the frontline nursing staff. I think the nurses on our surgical floor and our medical floor have done an outstanding job. All of our surgical patients had to be moved to medical floor for almost 2 months, and because we were holding the surgical unit as our isolation area for COVID-19. And so all of our patients were moved up to medical, and the nurses there, with the help of our nurses from the surgical floor, did an outstanding job in taking care of our surgical patients. The operating room staff has done an outstanding job in adapting to this the situation we've had with in the operating room. We have certain protocols we follow, but during this time we've had to use increased PPE and different types of masks, different types of gowns. Sometimes the respirators have been used. These patients have to be intubated sometimes, and there's an exposure to airway, and so the OR staff has done a great job. So office staff, my nurses I mentioned earlier, have done a great job in adapting to this. The anesthesia department, the lab, down to the housekeeping staff and the maintenance staff. I think we've really worked well together to pull through this time that's been different for all of us. Speaking for myself and for other surgeons, we don't accept change very readily. We like our routines. That's what we feel, that we are safe by doing everything the same way every time, and we feel it's safe for our patients to do it that way. And so, and we're all type A personalities. We just don't like change. But I've been pleasantly surprised at how well everybody's adapted and worked together to get through this. We're not through it yet, but we're going to get there.
Yeah. One other question, unless nothing pop up, that I just wanted. You mentioned something about the stays in the hospital, and they're trending down. Particularly certain patients can get out here a day later, and it crossed my mind. I'm sure our listeners have heard the word minimally invasive joint surgeries.
Yes.
And that's part of the world that you live in, is those kind of conversations. So just help us to understand,
Right.
How does minimally invasive joint surgery compare to what we do here at CGH?
Yeah. And actually, I'll have to talk about it separately for knees and hips. A minimally invasive knee replacement was something that everybody latched onto. Smaller incision and supposedly a quicker recovery. And we learned from that you need enough of an incision for a knee replacement to do the job properly. It's very important to see everything well and to be able to attach the implants properly and in good position. And so, as I've seen patients in my office who had, quote, minimally invasive knee replacement surgery elsewhere, their incisions really don't look a lot different than mine in terms of the size of the incision. Hip replacement's different. There is something really to a minimally invasive hip. The new anterior approach for hip replacement is new. It is being evaluated. It could be better in certain situations, and so it's not for everyone, but it is something that it could be a better way for certain patients for hip replacement surgery, and we've studied it, and we're looking into implementing it. We've even looked into robotic surgery for knee and hip replacements. Now, we're not there yet, but it's something we're studying and may implement at some point in the future.
Great. All right, well, Dr. Hanlon, thank you.
Thank you.
Dr. Hanlon has been a rock for us at the hospital in terms of our medical staff for many years. I've been here since 1997. When I came here, you already were an established leader and done some great stuff here in the community. I just want to thank you, and thank you for taking the time to be with us today.
My pleasure. Thank you very much. Thank you.
Okay, so as Dr. Hanlon exits stage right or left on your screen, Dr. Ali Khan is going to be joining us. Yeah, thanks. So, Mir, that chair over there where, not the one Sean was in, but there you go, and just roll it this way. Come this way, there we go. A little bit of staging here, and then we'll have Dr. Ali Khan to chat with. There you go. And just a little bit more that way, a little bit more that way, and then face the camera. There you go. Okay.
Thank you.
Look good, Dana?
Yep.
All right. Welcome.
Thank you, Bill, for having me.
Yeah,
Thank you for the
yeah.
opportunity.
Yeah. So speaking of medical staff folks who are well respected and do a great job for our community and have for a number of years, Dr. Mir Ali Khan is our hematologist oncologist here at CGH, and he and his staff do a wonderful job taking care of our patients. And I wanted to give him an opportunity to kind of ask him some questions about life now in this new normal that we're experiencing with COVID. So I'm going to ask you the same question that I asked Sean to start our conversation. What's been the biggest challenge for you since this COVID pandemic started?
Well, it has been very challenging for us to deliver the optimal cancer care during this crisis without jeopardizing patient outcome, at the same time protecting them from getting infections, protecting
Sure.
our staff.
Yeah.
And as you know, there is a little chance that a person can get COVID infection, but somebody who has cancer, there's a 100% chance it's going to progress.
Yeah.
We don't address that.
Yeah, so if
So
you're,
that is the
yeah.
biggest challenge.
So for these for people who have cancer, their immune system is compromised.
That's right.
And so their risk of
Yeah.
getting sicker is much greater. Yeah, I can see that, yeah. So, cancer, so how do you, tell me some stuff that you and your office are doing to try to help patients through that, because cancer doesn't stop just
That's
because
right.
we have a pandemic going on. So can you speak to that a little bit, Mir, and speak
Yeah.
to the camera there so they can
What we are doing now is to prioritize patients. You know, just to put in simple words, if you are treating patients for cure, meaning stage 1, stage 2, stage 3 cancers, we are not stopping the treatment at all. In stage 4 patients, any stage 4 cancer patients, it depends on what kind of cancer they have. For example, breast has better response than lung. Then we talk to the patient, look at their age, look at their performance status, and if possible, tweak the regimen a little bit.
Okay.
You know, some of the chemo drugs are available in a pill form, for
Oh.
example, in the colon cancer, so we have to tweak the regimen a little bit, and we spaced out the chemotherapy.
So some of them are getting oral,
Yeah,
oral
some
agents, maybe.
whenever
Yeah.
we can, yeah.
Yeah, that's good.
Yeah, I can give you an example. I have one patient who we treated for, is still getting treatment for cancer of the rectum. And the protocol was to give him chemotherapy first, radiation therapy, and then surgery. He got all this done. And after surgery, he had 3 more months of chemotherapy.
Wow.
So after he got the first cycle of chemotherapy, then COVID started, and he backed off. He said, I'm not showing up.
Mm.
So I had to convince him, talking a couple of times. After 6 weeks, he agreed to come to us. So on him, I tweaked the regimen. Instead of giving the IV drug, it's called 5-year reversal. We had a pill for that. So he was very happy about it. He's getting the pill now.
Okay.
Staying home.
Yeah, yeah. So you've had to make some accommodations.
Accommodation.
Yeah.
And one more thing that we are doing, as you know, the chemotherapy causes suppression of the immune system, and they are prone to get infection. For some chemo regimens, we give a shot called Neulasta to produce the white count
That's
so that they don't get sick.
Neulasta? Yeah, okay, yeah. Okay.
So that is not done for each regimen. We do only for high-risk regimen. But as the COVID crisis started, what we are doing is for even intermediate risk patients, we're using that Neulasta to protect them.
Sure.
Yeah.
So this Neulastin is a basically makes your white blood cell count go
That
up.
scales up, yeah.
White blood cells help you to fight off infection.
Exactly.
So you're being more generous in
Yeah.
the use of Neulastin.
Yeah.
Perfect.
Because
yeah.
you know, as per the guidelines and FDA, there are some stipulations. One particular regimen, it has to be done. The other regimens depends on the situation, depends on the age of the patient, other comorbidities, etc.
Yeah.
So we have been being a little bit lenient in using that growth factor support.
Okay, yeah, that makes sense, sure. I always ask our physicians who come in here, tell me, your office is much, if not more so than other offices, how have you set up your office and the flow of patients to keep them safe during this time?
Well, I must admit that CJ administration have done a great job. So there is a system in place. Everybody gets screened, they get phone calls, they are told if they have got fever, cough, not to come to the office, go for triaging COVID-19. And then when they come in, they get checked out for all these symptoms. I recall only 2 people after coming to our office, we had to do the COVID testing. Unfortunately, both of them were negative.
Okay, so there was you had some concern, but it ended up not being.
That's right.
And I don't know if you heard when Dr. Hanlon and I were talking, but the reality right now in healthcare, I mean, is that we have all those pillars going for us that we follow, and we follow those very carefully. If you're out and about, to be in your office, to be in our hospital, is probably a lot safer
Absolutely.
than being
safer.
at the hardware store.
Absolutely. It has been a change in culture for us, standing in the line to get our temperature checked before we walk into the office.
Yeah, I mean, you have to do that too, yeah.
That's right.
Yeah, okay. One of the things that crossed my mind when I was thinking about our conversation was, the need, so cancer in general, it depends on the type, right? But you start going a couple months, 3 months, and you don't do the things you need to do, those stage 1s go to 2s, go to 3s, go to 4s. So what are your feelings about patients and beginning the process of doing screening tests, like mammograms, colonoscopies, PSAs? I'm sure I'm forgetting some stuff, but what would you say about that?
It's a great question, Bill. People who are at average risk, meaning, let me give an example of breast. Average risk meaning no family history and they do not have any bad genes, those mammograms could be delayed in a couple of weeks or even a couple of months. But somebody is at high risk, meaning if they got the BRCA gene or a strong family history, then I would recommend that they should be getting mammograms as scheduled.
Okay.
And same applies for colon cancer. Now we started screening at age 45. But if somebody is at high risk, meaning family history, or they've got the bad gene, that is syndrome called a Lynch syndrome, they should not miss the colonoscopy. Otherwise, it could be scheduled maybe 2 or 3 months out.
Okay. Yeah, that's good to know, because I know we're beginning the process now of offering patients the opportunity to catch up. Maybe they saw the GI people, our GI department, and there was time for their colonoscopy, and now if they've had that history, it's appropriate to.
Yeah, as I told you, for the treatment we are prioritizing. For screening also, we need to prioritize patients who need to be screened right now or who could be delayed a couple of weeks.
Yeah. Because the one reality that I don't know, and I don't think either one of us do, is how much longer some of the restrictions
That's true.
are going to be in place for.
If next time beyond summer, maybe fall, we don't know. It's uncertain.
Right, and I'd sure hate to. I get it holding off at first, but at some point in time,
We need to get it done, sure.
yeah. And while I have you here, I think a lot of folks know about the mammograms and colonoscopies and PSAs and those kind of things. Would you speak to a little bit the lung CT scan and what the recommendations are on that?
Yeah,
Because you deal with a lot of lung cancer, and
that's
I think it'd be a good conversation here.
Bill, lung cancer is one of the very common cancers, throughout the world. It's number 2 here in the United States. And started with smoking and COPD, and we got a lot of patients. So the initial screening tool, we didn't have much, just X-ray, and that was useless. Now the low-dose CT scan has made a very remarkable change, and we are picking up cancers early, so they are resectable, they are operable, and eventually it is altering the outcomes of the patients are living longer because they're diagnosed early. And since we started, I don't remember the date exactly when we started, the first lung cancer screening patient was diagnosed with lung cancer.
Really?
Yeah.
Wow.
And
Okay.
she had surgery done, she's doing great.
Yeah, no, that's pretty unusual. I mean, yeah, okay, yeah. All right. So, and just so the folks who are listening, if they are a smoker or used to smoke or know people that smoke, you want to kind of walk through in this low-dose lung CT scanning who meets that criteria to have that
Yeah,
done?
no,
How
those-
often?
First of all, it is very safe. There is no injection of contrast, and the exposure of the X-ray is very minimal. So there are criteria, and there is an age criteria. I believe it is 55 onwards. We cannot screen below 55. So we can't, and they should have not quit smoking less than 15 years. So there is a very restrictive criteria
So
to
for
qualify for the screen.
So they quit smoking within the past 15 years, they still are
They still-
candidate.
they
If
still can
if they
get
quit
that.
when they were in their 20s and they're 50s now,
They can't.
they're okay.
They are not eligible.
They don't need that.
They don't need that.
Right. And if I remember right, it's every year. Is that
Yeah,
right?
it's every year.
Yeah.
Every year, once a year,
Okay.
like mammogram.
Yeah. Because the idea is you're going to catch something early.
Yeah.
And you can take
Yeah.
that out and
Yeah, the biggest challenge we face, comparing to mammogram and lung cancer screening, getting a biopsy from the breast is very easy, it could be done by a radiologist, but the lung biopsy, it takes a toll. There is a high risk involved of breaking the lung, puncturing the lung, and causing what is called as pneumothorax that requires tube. So it's a little bit tricky. It's not as patient friendly as mammogram.
yeah. Yeah. Good. I just wanted to make sure we ask about that because I know it's beginning more, and we do that. By the way, we do those lung CT scans here at CGH.
Yeah, we started doing that.
yeah, so-
I did it about 2 years ago.
Yeah. So I just want folks to be aware that that is an option here. Let's see here. Okay. I'm just looking at my questions here that I have on the phone that Dana sends to me. I wanted to talk a little bit too while I have you, because I think it's really interesting now, is what's going on with immunotherapy and some of these new drugs for immunotherapy and how that is having an impact on some of these cancers that we used to hear, oh my goodness.
Yeah.
And now we're able to say a little bit more, give a little more hope to those. Do you want to speak to that?
Sure. Immunotherapy has totally changed the paradigm of how we treat cancers. In general, cancers were treated with chemotherapy. Those are the drugs, the chemical toxins, they go inside the body and they kill every dividing cell, not just the cancer cell. And that's why we get side effects like hair loss, like diarrhea, like the bone marrow suppression, meaning the blood counts go down. But immunotherapy works in a very different way. And this has been studied for more than a century. People had an idea even 100 years ago that our body has an immune system and that can fight the cancer. But to put in practice and to prove this concept was very, very challenging. Fortunately, in the last 10 years, there has been a big leap in the research in immunotherapy. So we have now drugs which can augment our immune cells, so-called T cells, and those T cells attack the cancer. So that's why we don't get the usual side effects like nausea, vomiting, or hair loss. But there are some side effects because our immune cells can attack our own cells, causing problems like diarrhea or causing endocrine problems, which you see very often, hypothyroidism and hypoadrenalism, those side effects are there. But it's very well tolerated and it has changed the outcomes in cancers like melanoma,
So
kidney cancer,
melanoma is skin cancer.
skin cancer.
Yeah. So this.
That was the first cancer where we had utilized immunotherapy, showing good success, because it was pretty chemo-resistant.
Yeah.
There was not a drug which could kill
There's no
melanoma
chemo drug.
cells.
That was a great drug for
There was
that.
only one old drug called dacarbazine. We were using that very dismal results.
Yeah.
So this was a major, major breakthrough having immunotherapy for melanoma.
If I remember right, isn't that like former President Carter? If I
Yes.
remember right, he has melanoma,
Yeah.
and that's part of why he's still alive is because he's doing immunotherapy.
Yeah, that's right.
Yeah. What other cancers are kind of seem to respond well to that?
Well, melanoma is number one. Kidney cancer. Kidney
Okay.
cancer is another cancer where we do not have chemotherapy. We don't know how to do that. There was a drug called interleukin, very toxic drug, very difficult to administer, but immunotherapy has changed the scenario. And then we have other targeted therapies in the form of pill. Immunotherapy is IV. Those drugs are mostly given either every 3 weeks or every 2 weeks. Now, recently we got an approval of the drug, which could be given every 6 weeks.
Okay.
So that is helping us out in this COVID crisis. Instead of a patient coming to our office every 3 weeks of chemotherapy, they're coming every 6 weeks.
Okay.
And immunotherapy has a great role in lung cancer, in bladder cancer, you name it, any cancer. Now, it has made a very major breakthrough in breast cancer.
Yeah.
There's an entity in breast cancer we call triple negative, meaning it's negative for the hormone receptors and HER. Breast cancer, we can think about hormone receptor positive and hormone receptor negative. So for hormone receptor positive patients, we have hormone therapy
Right.
and very effective chemotherapy.
So you want to have hormone positive if you can.
Yeah,
That's what
yeah.
you like. Yeah.
So patients who have triple negative, meaning ER negative, PR negative, HER negative, we didn't have any good drugs. We used to treat the same way, but the response rate was not that great. Now immunotherapy has made a major breakthrough in treating
Yeah.
triple negative breast cancer.
That's great. That's great. You know, it kind of dovetails a little bit into this COVID stuff. So we're talking the same immune system,
Yeah,
right? The same immune system that we're wanting to fire up to be able to fight off
Yeah.
COVID is the immune system that we're utilizing to help folks with cancer.
yeah,
And the side effects of those cancer drugs can sometimes, there's your immune system kind of fights.
your own cells.
Yeah, and so this COVID, part of why the people that don't do well, is that in many ways their body is either failing to respond or over-responding to the COVID infection.
That's right. It's kind of an overreactive immune system. There is a release of cytokines when the coronavirus infects the cells.
Right.
And that is causing
Yeah,
all the symptoms, ARDS, and multi-system failure, and things like that.
yeah. So our
Well,
immune
if you give me one moment, I'll explain to you about immunotherapy a little bit more.
Go for
because
it.
This is a very neat concept. Here is a cancer cell, and here is our immune cell. Normally, the immune cell tries to attack the cancer cell, but the cancer cells are so smart, they release a chemical which puts a brake on the immune cell. So these drugs release the brakes.
Okay,
So when the brake is released, the T cell, they act on the
they can
cancer.
just go do their thing.
Yeah, in so doing, they may attack our normal cells too.
Okay,
So that's why we need to have a balance.
sure.
I do have a couple of patients who have some side effects, basically thyroid problem or what is called as pneumonitis, which is an inflammation of the lungs. That's what we are seeing with ARDS, with the coronavirus,
Yeah.
similar things like that.
Yeah.
So we have to be very cautious in monitoring those immune side effects and giving a break to the immunotherapy
Yeah.
if that happens.
Yeah, okay. Okay, and what else did I have that I wanted to make sure I get talking about with you? Yeah, I think that's the big stuff. Anything else that as we're talking that you wanted to speak to? Any questions that you were like?
Well, I would like to take this opportunity. I've been in oncology for a long time, more than 3 decades, and I've seen lots and lots of developments. I mean, if you allow me, I can share one or two
Yeah.
things which are happening, which is amazing. I never expected in my lifetime this would happen. One is a disease called chronic myeloid leukemia, which is a cancer of the bone marrow. And when I was in medical school, the average lifespan was 2 years, and the only treatment we had was a bone marrow transplant from somebody, from sibling or from unrelated donor. And now just 1 pill a day, which is called Gleevec, imatinib, that has cured more than 90% of the patients.
Wow.
This is amazing. Gleevec, imatinib, that is the poster child of what is called as targeted therapy. We have been lucky in this disease because we know there is only one mutation. Maybe you heard about that, called Philadelphia chromosome.
Yeah.
So there is one.
I'm sure our viewers may not, but that's a medical school thing.
Because that was
That's a
discovered in the
test question.
Philadelphia. We give the names funny names to each disease. So there's only one mutation, meaning one change in the gene that caused the disease, and they were able to target that. In other cancers, we are not that lucky because other cancers could be the result of multiple mutations, not just one mutation. So it's very difficult to design a targeted therapy for every cancer.
Yeah.
So we have to combination of chemotherapy,
Right.
immunotherapy, and targeted therapy.
Right.
The other amazing outcome has been multiple myeloma. The multiple myeloma, if you remember from medical school, the average survival was 2 years.
Yeah. So
Now we're seeing 10 years.
That's bone cancer.
That's
for
bone
those-
cancer.
Yeah.
It's a bone cancer where the bone marrow cells produce a lot of myeloma, so then they destroy the bones, they cause fractures in the bones, cause holes in the skull bones, and the renal problems, so many other issues. So the treatment for that disease was chemotherapy or a stem cell transplant, still the transplant, but we got new drugs and better drugs, and people are living. I know one of my patients here was diagnosed in 2005, still doing well with multiple myeloma.
Wow.
So this is amazing. We got amazing drugs.
Yeah.
And on the contrary, in some cancers, we have de-escalated the therapy. For example, in breast cancer. Breast cancer, anybody who had tumor more than 2 centimeters or 1 centimeter or has got a lymph node, they used to get chemotherapy. Now we are using testing to find out whether they have the good gene or the bad gene in the tumor tissue. So there's a test we call Oncotype DX assay, and that will tell us whether the patient will get benefit from chemotherapy or not. By doing that test, we are able to spare about 25% of the patients from chemotherapy.
Yeah.
I mean, this I
amazing.
never imagined.
Yeah.
De-escalating the treatments.
Yeah. That's so cool.
There are a lot of exciting things going on in
Yeah.
oncology.
Yeah, so 25% of the folks who get breast cancer now
Who are ER/PR positive,
don't
they are
need.
spared of chemotherapy.
Wow.
So
Yeah.
in our hospital, we got a protocol. The pathologists are pretty much aware of that. When the surgeon does the surgery, and the pathologist knows the criteria in whom to send that test. So by the time patient comes to see me, I already have got the test results, and I can tell them, oh, you need chemotherapy, you don't need chemotherapy.
Yeah. And I would tell you that Dr. Ali Khan does a great job. He heads our cancer committee and our cancer peer review, and well, not during this COVID situation, but typically every couple of weeks, we get together and go through and make sure that every person who gets that diagnosis of cancer that we're
Yeah.
talking through and
That
learning
is a
about.
very amazing exercise we do every 2 weeks, every Thursday. So all the doctors, primary care doctors, surgeons, radiologists, pathologists, nurse practitioners, we sit down and on the big screen
And our
project
radiation oncologists.
radiation oncology. So
Yeah.
on the big screen we project all the slides of the pathology, we look at the scans, and then we come to a consensus of the best management for each newly diagnosed patient.
Yeah, so I'm really proud of our CGH. This community hospital I'm telling you, that's a big deal that we offer our patients, and Dr. Ali Khan is a big part of that. So hey, I so much appreciate your time.
Thank you very much. Thank you for having me. Thank
Appreciate
you, folks.
having you
Take
here,
care and
and,
be safe.
Yeah, thank you so much. And I have a few more questions I just need to answer for the audience before we go, but thanks,
Thank you.
appreciate it. So there were a couple questions about that I got from Dana. One question is about COVID-19 and is it changing and mutating? And what I would say so far is what I have read is that a little bit, but not so much that it's affecting the ability for us to make a vaccine and for how that vaccine to be effective, or for someone to get exposed a second time and it's mutated so much that they get really sick again. So right now, at least, it seems pretty encouraging in terms of this mutation situation. The other thing a couple other things I wanted to speak to. Speaking of immunizations, so it's kind of ironic that we're hoping that sometime in the not too distant future we'll have an immunization for COVID. I'm reading more and more that we're falling behind in terms of immunizing children. So I just wanted to take this moment, particularly those kids under the age of 2. But I just wanted to take this opportunity to encourage parents that take every opportunity to get to your pediatrician for that well child visit, to have evaluation, and also to get your child's immunizations. It's ironic in that we're looking for an immunization for COVID, and yet we're falling behind on the immunizations to prevent infections that we already know that we can prevent if we get these immunizations for children. So please, I hope as we're talking about what we're doing here at CGH to make things safe for patients, that'll help, because I know there's some fear about showing up to different places. I think the benefits of getting your child immunized outweigh any fears about having them come to a healthcare facility. I really do. And I'd also would take this opportunity to say there are definitely some adult immunizations that if you get those, they also can be really helpful in terms of preventing things that you don't want to get. So there's certain strains of pneumonia that you can get immunizations for, which also can cause people to die. There's things like shingles immunizations that won't typically cause you to die, but it's pretty uncomfortable. And yeah, there's tetanus and pertussis and diphtheria. There's something called HPV now they're recommending for folks who are younger, even through, I forget the age now, but HPV helps to prevent cervical cancer and some throat cancers and penile cancer. So yeah, to me, this situation just speaks to how important these routine immunizations that we take for granted, they are not routine, and should not be taken for granted. Great opportunity for me, at least in my mind, to see how important these are. So wanted to talk about that. I try every week to talk about some place at the hospital here that's doing really good work, and I wanted to just mention this week, this is EMS, or Emergency Management Services Week. I want to give a shout out to that group of folks. So those are the folks that you see go around town in our ambulances, and they're responding to people who are having problems health-wise in their homes. They respond to accidents. They're the folks that, man, they're showing up and they're taking care of some really significant situations. They are the tip of the spear here at CGH. And I just want to thank them so much for the work that they do. Big part of the work that we do. And then so they get folks and get them stabilized, they get them back to our emergency department, and our ED team goes from there. But just want to make sure I give a shout out to them this week for EMS Week. Happy EMS Week to our EMS staff. I'm sure most of you know that I think it's going to be May 29th that we're going to be in phase 3. And so I would just encourage you to make sure you take a look at the IDPH website in terms of what that means and doesn't mean. I will just emphasize that I'm not an epidemiologist, I'm not a statistician. Phase 3 still has things like trying to keep gatherings to less than 10 people, to continue to do social distancing as the norm. These pillars of hygiene, distancing, doing screening, masking, they should not go away. And I think time will tell in terms of how people are opening up different states. We'll learn from this, and we'll learn what was okay and what wasn't, and why it was okay and why it wasn't. And I'm glad that the governor made the decision that the governor made. I just would encourage folks to just kind of take that next step without going too far, without going beyond that, I guess I would say. Because there still are some sobering numbers out there. By June 1st, the expectation is that 100,000 people will have died from COVID since it started, and it kind of started, as you all know, sometime in that late February, early March time. And by June 6th, the number is supposed to be around 113,000. So that's not an insignificant number, and the time frame from when you get exposed to when, in general, we see the death numbers are about 3 weeks. So, whatever states do in terms of opening things up, how that's going to affect folks is going to be about a 3-week lag. And, at the end of this, we're really trying to protect our most vulnerable folks, which tend to be more heavily hit by this disease. So I think Dana said that we're having some technical issues, that a tower went down, so I'm not getting as many questions as I normally would. If you do have questions, either we'll catch those next week, or if you wanted to send a post and send that, and Dana and her team will kind of work with me, and we'll try our best to answer those. Thanks once again for all of you for tuning in and listening, and stay safe, and hope you have a great week, great Memorial Day weekend. Thanks.